and the leaflet is quite abnormal. It looks like as though there's like a lot of cardia and redundant cardia. And the short axis view, it appears like as though there may be a cleft. We're not 100% sure. And when you do a typical four-chamber view, see this anterior leaflet is quite large. Whether it is large or whether the posterior part of the P3 part of the posterior leaflet is large, we're not quite sure. And here is a commission of the two-chamber view, commissioner view, P1 and P3, and that's A2, it should be. So color flow clearly shows that the severe MR, large areas of convergence, but the jet alone is seen right here as though there's a problem with the leaflet. But when you do a 3D on the same patient, look at this leaflet. It's quite bizarre leaflet. It looks like a very small anterior leaflet. There's a large P1, and this P2 area is flared, and P3 is also big and is also prolapsing inflamed. So this is a tricuspid valve, this is aortic valve. So this is the anatomical clarity that the 3D provides, which sometimes very difficult to obtain even by 2D, even with expert hands. And when you look at the ventricular aspect, look at this leaflet. Looks like a tri-leaflet valve, what we saw. Here is what we saw there was a cleft or a commissure. It looks like a clearly a commissure. Now, even though 3D can be obtained by transthoracic, but if you want to do any intervention, I think it will be a good idea to look at the 3D because it provides a lot more information. Here is the schematic where you see the TEE probe that's going down. There's a little bit retroflex, and as it goes along, this is your aortic, and A1, A2, A3, P2, P3. And if you look at this, clearly you can identify A2 and P2 very nicely. So where the view is coming, how it is, depends upon how you rotate. The same thing if you rotate it to 45 degrees using the electronic or your handle, then it has to go through the commissures. See the commissural view. A1, let's speak the P1, P3 and A2 in between. P1, P3 and A2. So this, and here is the view where you can see in the commissional views, if this is flared, this is P1, and if the center one is P2, and this is P3. It's easy to look at, but here also one has to be careful. You can move the scanner medial to lateral, coming towards the aorta and going away from the aorta to the lateral wall. Then you will look at the A2 involvement. So here is the commissional view where there's a flared P2, nicely seen. And here there's a flared P1. So here is a left atrial appendage, coronary sinus is coming here, and you see this. Here also, 3D plays an important role. If you look at it here, the volume image that goes through completely interrogates the mitral valve nicely, and here you see this is not 3D, but this is the grasping view, where it is the money view for the edge-to-edge repair, where you want to see the anterior leaflet, which is the largest leaflet, and medial or lateral according to the you can position. So this is the one which I was talking about, volume image. When you look at it, it covers the entire mitral orifice very nicely. You can see the structure very nicely. Here is the aortic root positioned as the anatomically corrected view, and you can turn the same volume on the image, and you can look at the ventricular aspect, which will clearly gives you the posterior commissure, anterior commissure, and you can clearly look at where the problem is. And when you're looking for the mitral valve intervention, the mitral regurgitation that's occurring can be misleading. From the left atrial side, when you see here the entire area is involved, as it looks like. Here, there may be a cleft here, or maybe the unusual, uneven length of the leaflets. I'm not quite sure. But whereas when you look at the ventricular aspect, the major regurgitation site is between A2 and lateral aspect of, medial aspect of P2 or even P1. So this area. So if at all when you look at this, then trying to go for this first will give you a better idea whether there is going to be a rest of the additional clips you had to put or not. So looking at the ventricular aspect in a complex jet gives you a clue where to go for. And here is another patient, looks like a Borlow's valve, everything. I'm not quite sure how many scallops are there, but certainly this is a anterior leaflet, and this looks like A3, which also looks like another separate leaflet, and P1 and P2, and P2 looks like 2. So here, look at the regurgitation all across. Here is a patient where you think that it's a P2 flail, and when you try to look at the commissural, it also looks like, here in this view it looks like a P3. It looks like P2, it looks like P3 here. And when you look at this, well, I'm sorry, I don't have the 3D of that one. I think I should have had. When you look at it on the 3D, it was P3. P3 was large, and that was encroaching on the P2 lateral aspect of P2. So that was the 3D clarity that we got. And here is a patient who looks like a very straightforward plain A2. A patient also has got a regional wall motion abnormality. In this patient, you got to be careful that am I just dealing with this, or could there be an element of functional also on top of it? And here, if you look at it, posterior leaflet mobility is somewhat restricted. It doesn't move. This cord is pulling it, and there's a wall motion abnormality from here going down. So this is being tethered, and there's also flame, which you can see that nicely. And color flow clearly, he clearly shows that posterior leaflet, posterolateral wall is hypokinetic, and this doesn't move, and anterior leaflet is overriding. And when you look at it, look at the pathology. And we underestimated this, the magnitude of the A2, which is quite large, and lateral part of the A2 is plain, and P2, where it is supposed to be closer, is hypokinetic and retracted. So it's a combination. So in this case, the cases nowadays you can address going for this and going for this, and you may be able to. But knowing these anatomical features allows you to plan your intervention very well. I think I will close with this. Thank you.